Esophageal cancer and Barrett's esophagus. Etiology, pathophysiology, and pathology. Risk factors for carcinoma of esophagus are shown in Table 29. Esophageal carcinoma is microscopically squamous cell or adenocarcinoma. Barrett's esophagus is defined as replacement of the normal squamous epithelial lining of the esophagus by metaplastic columnar epithelium. It is strongly associated with chronic gastroesophageal reflux of acid, which is thought to damage the normal lining with replacement by columnar, acid-resistant lining. The main importance of Barrett's esophagus is that it is probably a precursor lesion of esophageal adenocarcinoma, with a 40% lifetime risk of this complication in patients with a segment of Barrett's greater than 3 cm long. Epidemiology. Worldwide, squamous cell carcinoma is most common. There are geographical variations in its incidence, with the highest rates, greater than 100 per 100,000, in China, Iran, and South Africa. In the Western world, the incidence of adenocarcinoma of the esophagus is rising rapidly for reasons that are unknown, and it is more common than squamous cell carcinoma. The true prevalence of Barrett's esophagus is unknown since many cases are silent and therefore not detected. About 10% of patients undergoing upper gastrointestinal endoscopy for reflux symptoms are found to have a columnar-lined esophagus, Barrett's, and half will have specialized intestinal type lining. Autopsy studies suggest a prevalence of around 1%. Clinical presentation. Common. Progressive dysphagia with weight loss is the usual presentation of esophageal cancer. Initially, subjects may have dysphagia for solids such as meat and bread, eventually reporting difficulty swallowing purees and liquids. May be discovered as part of the workup of iron deficiency anemia. Barrett's esophagus may be asymptomatic, or it may be discovered as a result of diagnostic tests for gastroesophageal reflux symptoms. Uncommon. Dyspepsia or heartburn. Pain due to local invasion into the spine or intercostal nerves. Hoarseness due to involvement of the recurrent laryngeal nerve by middle and upper third esophageal carcinomas. Rare. Tracheoesophageal fistulae. Physical signs. Signs may reflect the extent and duration of disease, with weight loss, evidence of complications such as aspiration pneumonia, and rarely hoarseness due to tumor invasion of the recurrent laryngeal nerve. Investigation and staging. Barium or gastrograph in swallow. This is the initial investigation of choice for patients presenting with dysphagia, Fig 27. Upper gastrointestinal endoscopy. The key test for obtaining multiple biopsies for histology and brushings for cytology for a tissue diagnosis. In Barrett's, the esophagus has a characteristic red, velvety, columnar epithelium extending proximally from the gastroesophageal junction, proximal end of gastric rugal folds, with biopsy confirming columnar metaplasia, Fig 28. CT of the thorax and abdomen. Undertaken to look for evidence of local invasion into mediastinal structures and for hepatic or pulmonary metastases. Endoscopic ultrasound. If available, this provides more accurate local staging of the tumor. Unfortunately, most are advanced at presentation, T3, with invasion through the esophageal wall into the adventitia, or T4, with spread into adjacent structures, e.g. aorta, pulmonary vessels. Differential diagnosis. Benign esophageal stricture, usually obvious at endoscopy, confirmed with biopsy and brushings, but repeat sampling if clinical suspicion but histology negative. Gastric carcinoma, usually from the cardia, invading the lower esophagus. Note that biopsy from a point distal to the squamous columnar junction, e.g. from the proximal end of a hiatus hernia, will lead to a false positive diagnosis of Barrett's esophagus. Treatment. Emergency. Presentation with complete or near-complete obstruction, liquids and liquidized food, is not unusual, in which case dilatation may be needed at the time of diagnostic endoscopy. NB. The risk of esophageal perforation is higher with dilatation of malignant compared with benign strictures. Short-term. Aim is rapid workup to select appropriate candidates, less than 1/3, for curative surgery, usually with thoracoabdominal CT and endoscopic ultrasound if available. Preoperative enteral or parenteral nutrition and physiotherapy are important. Subtotal esophagectomy with anastomosis to fashioned gastric tube is often employed. Long-term. Palliation indicated in most cases, with either endoscopic or radiological positioning of expandable metal stents, laser photocoagulation, or radiotherapy, internal or external. Complications. Esophagectomy. Anastomosis may leak or dehisce, has less rich blood supply compared with rest of intestine. Esophageal stent. Perforation during stent placement and laser photocoagulation. Stent migration. Prognosis. Morbidity. Aim with the majority is palliation, i.e. ensuring reasonable swallowing. Mortality. Overall median survival less than 1 year, 5-year survival rate 5%. Earlier stage and absence of lymph node involvement yields better results. There are 5–10% mortality with esophagectomy. Prevention. Primary. Aggressive suppression of acid secretion in patients with Barrett's esophagus or reflux esophagitis. Long-term acid suppression may arrest or reverse Barrett's changes. Endoscopic surveillance for adenocarcinoma. This involves yearly endoscopy with multiple quadrantic biopsies, particularly if the segment of Barrett's is long, greater than 3 cm, and shows intestinal type metaplasia. Junctional and gastric type metaplasia probably have very low malignant potential and are not usually surveyed. Endoscopic ablative therapy. The role of laser, photodynamic therapy, or electrocoagulation to ablate Barrett's esophagus is unclear, but may be considered for those who have high-grade dysplasia or carcinoma in situ and whose comorbidity prevents surgery.